Thank you, sir. Uh, because of paucity of time, we'll have to move ahead. And I welcome you all for this first afternoon session in this hall. It is about tackling tricky and complex situations in Phacoemulsifications. I would like to invite the speakers to take the front seats, please. And I'll be going with the first talk.
Just to introduce the Chief Instructor, Dr. Vanushree Nair. She's a prolific left-handed cataract surgeon who believes in innovations and has picked up into the big league very fast. So over to you, Vanushree.
Thank you for the kind words, sir. So I'll begin with my presentation. I'm talking about floppy iris and the small pupil and how you can safely manage these cases. So let's begin. So as we all know, it is a triad called IFIS, where what happens is there's an intraoperative billowing of the iris, there is progressive meiosis, and prolapse of the iris tissue through the clear corneal wound. So there are three grades of IFIS: mild, moderate, severe, and as you can see in this order, if you have all three, then definitely it's grade 3. It's more common in males, we know that all, but you should always remember that there are females who can also be affected by IFIS. So history of hypertension, diabetes, hypothyroidism, they are on multiple drugs, and these drugs can also cause IFIS. So this is an exhaustive list of drugs which can cause IFIS. We all know tamsulosin is implicated, but also we should keep in mind these other drugs. And if the patient is, bronchial asthma patient using inhalers, schizophrenia, antipsychotics, antiplatelets, all these are also implicated. So first it was described by Chang and Campbell in 2005, and it is the blockage of the alpha-1 adrenergic receptors, and that affects the dilator muscles of the pupil, that is the iris, and that's what happens. So clinically, what we should look out for is sometimes what you will have is a smooth, featureless iris. If you look at that, and if the pupil is not well dilating, then you should keep IFIS in mind. And if the other eye has been operated before, then look out for iris atrophy and all these features which will give a clue that the surgery went difficult at that time. So how do we manage IFIS? So first, as I said, be vigilant about it. Look out for subtle signs of IFIS, a moderate dilating pupil, fluttering of the pupil margin when you go in, and so on and so forth. So let's look at the first case. So this was a case which was moderately dense nuclear sclerosis, planned for a toric cavil, and a moderately dilating pupil. So I thought that it's okay, I can proceed ahead. I do my incisions, I do the hydrodissection, and this is where actually the things begin, that the pupil has started coming down. And so now I know that this is somewhat kind of a mild to moderate IFIS, but I decide to manage without a pupillary dilating device. I proceed ahead. I am going ahead with my trench, dividing the nucleus, and as you can see that the pupil keeps coming down in between when the chamber is not completely stable. So here when I come out, you can see that the pupil has come down. I wanted to put more viscoelastic, heavy dispersive viscoelastic, so that the iris remains down and doesn't come out of the wounds. So I go in again, I do the subchops, and I'll speed up a little because I want, here you can see that the iris has started coming to the side port. A little bit of iris is coming and trying to plug the side port, but I continue. It is not a very leaky wound, so I know that it is going to be okay. As I proceed ahead, I thought of hydrating the side port. This is another trick that you can use if your iris is popping out. So what this does is it seals the wound a little bit and makes life a little more comfortable. But as I'm proceeding ahead, the iris decides, no, I'm going to be a little more mischievous. And it starts slightly popping up, but I'm much more comfortable here and can proceed safely. So when you're doing irrigation aspiration, when you go in, ensure that your irrigation is off when you go in, otherwise the iris can pop out. And also the bottle height should be a little low, so that bottle height or the IOP, so that the chamber is not too tight and gives a reason for the iris to pop out. So here you can see that the pupil has come down, but it is okay. I can still comfortably go and implant the IOL, check the toric marking alignment, and that's done. Coming to the next case, here what happened is, again, a moderately dilating pupil, but this patient had, the other eye also had IFIS, so I knew that this can trouble me. You can see the little fluttering, not much, but the pupil is not dilating with the adrenergic agents. So here I decided to use a pupil dilating device, that is a Malgin ring, so that my life is much more comfortable when I'm going and doing the phacoemulsification. So I've just demonstrated here how you can use the Malgin ring to keep the pupil well dilated. So you engage all the scrolls into the pupillary margin using the Kruglin's hook. And there you have a well-centered opening. We can very comfortably do the rhexis. That's the end of the rhexis. And as you do hydro here, you'll see that the iris is, trying to come out at the main wound. There the irises come out. So here, actually, I should have just moved the Malgin ring a little away, and it would have taken things in this thing, but I had to take the iris in first. Go in with your phaco probe, and I'll just go a little ahead because this is a normal nucleus management of the case, which is much more comfortable again because the pupil is well behaved and the iris is not popping out. So here, as I end the phacoemulsification, you can see that the iris is tending to be out from the main wound. So imagine if the Malgin ring was not in place, it would have been quite a troublesome thing to deal with. But here it is okay. I put a dispersive viscoelastic to again, nudge it in. It's again tending to go out, so I'm tempted to use the iris repository through the same wound, but ideally it should not be done. You put a dispersive viscoelastic there and the iris stays back because you need to implant the IOL, which will be easier if the iris is not popping out over there. So there goes in the lens, and you take the Malgin ring out, and there comfortably your surgery is over. So take home points are that you need to be vigilant that IFIS can present anytime. Use lower IOP, smaller wounds, use the dispersive viscoelastic to control the movements of the iris. And if you're suspecting a severe IFIS, please use a pupil dilating device. You could use either of the rings, or even the hooks do very well. And constrict the pupil at the end because you don't want the iris popping out later in the postoperative period. Thank you so much. So our next speaker is Dr. Harshul Tak. Unfortunately, he was not able to make for the conference this time, but he has sent his presentation in the form of a video. He is presenting on black and brown cataracts. Can you please play the video, Dr. Harshul Tak? Loaded on. He's a senior consultant at Jaipur and a very prolific surgeon. Let's hear his presentation.
Good afternoon, everyone. At the outset, I'd like to thank Dr. Vanashri Nayak for giving this opportunity to be a part of our instruction course. So today I'll be talking about how to do safe phacoemulsification in brown, black, and white cataracts. We all know that to deal with these kind of cataracts is challenging even for an experienced and skilled phacosurgeon. So the technique which I use to deal with brown and black cataracts is what I call drill and chop technique, which I presented in ESCRS Paris 2010 and 2011 in ESCRS Vienna. We all know that the main problem in brown and black cataracts lies in the dense central endonuclear core and thick leathery posterior fibers. So it's very difficult to crack these kind of dense nucleus. So after making side port incisions, it's always useful to stain anterior capsule in these kind of cataracts because you can easily visualize the margin of capsular axis when you are doing phacoemulsification. Coming to the sizing of the capsular axis, The size has to be around 5.5 millimeters. It should not be small because a small capsulorhexis may get damaged while you're chopping the nucleus or while you're taking out these sharp and thick nuclear pieces. These hard nucleus are going to take up more ultrasound energy of phaco machine. So we need to protect the corneal endothelium by using chondroitin sulfate based OVD like Viscoat. Now coming to nucleus emulsification, I start drilling in the center of the nucleus and deeper down in the central endonuclear core. So by drilling like this in the center and deeper, your two purposes are solved. Firstly, you weaken the dense endonuclear core, and secondly, you get a good deeper purchase of the nucleus and your chop becomes much more effective. So now after drilling, I'm holding the nucleus and chopping the entire thickness of the nucleus all the way down. As you can see here, I rotate the nucleus 180 degree, hold it another side and complete this crack. So now once you have this complete division of the nucleus, you rotate it 90 degree and again divide the nucleus into smaller pieces. And after dividing it into various smaller pieces, you can easily take them out one by one like piece of cakes. As I said, these are denser nucleus. You need to replenish OVD also in between so that you protect corneal endothelium all the time. And try to emulsify away from the endothelium in the pupillary plane. Most of these harder nuclei, they have very little of epinuclear cushion there. So you need to be very careful while you're coming to the last pieces. And this is how you finish the nucleus emulsification. And this is a hydroplantation technique which I described in 2010. You just put irrigation cannula in the anterior chamber and the single piece IOL, it goes in the capsule bag and you don't need any OVD there. Coming to white intumescent cataracts, the problem in these kind of cataracts is that there is increased intracapsular pressure because of the liquefied cortical matter. So capsulorhexis becomes challenging in these cases. So after staining anterior capsule, we go ahead and use high molecular weight OVD and use a technique which I call sequential two-stage capsulorhexis. And here I go ahead and make a very small curvilinear cut in the anterior capsule using a cystitome. Go ahead and again put OVD in front of it and use a microcapsulorhexis forceps to make a very small opening in the center of the anterior capsule. So this central area is the safest area where you can make small capsulorhexis. And it's very important to debulk the capsular bag before you start enlarging your capsulorhexis to definitive size. So I use a 27 gauge cannula, go from main port, and you can see the entire liquefied cortical matter is coming up in this cannula. But this is not enough. You need to go from one side port and debulk from this area. So because this liquefied cortical matter is all around in the capsular bag, I go ahead and from other side port as well to debulk so that you can debulk the almost all the entire capsular bag. And then I go and give an oblique cut there in the anterior capsule and use a microcapsulorhexis forceps to complete the capsulorhexis, which is of definitive adequate size. Coming to a white cataract, which is a Morganian cataract, the The problem in these kind of cases is that there is a whole lot of liquefied cortical matter which is there inside, and the moment you give nick in the anterior capsule, the entire liquefied cortical matter comes out, obscuring your view and making it very difficult to make capsulorhexis. So as soon as you give a nick here in anterior capsule, you will see that the milky fluid is coming out. Even when you are trying to make capsulorhexis, again milky fluid is trying to come out. So you go ahead and again wash this liquefied cortical matter. And another problem in these kind of cases is that anterior capsule is very fragile and zonules are weak in these cases, and they have a lot of anterior capsular plaque. So you need to be very careful while you are in capsulorhexis. And once you have the capsulorhexis, the another problem lies in the freely mobile hard nucleus in most of these cases of Morgellon cataract. So the technique which works best in these cases is of horizontal chop. Go ahead and drill in center, get a good hold, lift the nucleus up, and get a chopper from equator. And you can see I'm able to achieve this crack in the nucleus. I go ahead and rotate the nucleus 180 degree again, hold it, and again divide this nucleus in two pieces. So once you have this division, you can further get chop and divide this nucleus in smaller pieces before you emulsify the entire nucleus. You can step down on your phaco settings whenever you are emulsifying the last nuclear fragments so that you don't get surge. And after that, you go ahead and put IOL in the capsular bag. So after putting IOL, if you realize that the overlap of the optic is too much, you can always go ahead and secondarily enlarge capsulorhexis to adequate size. Here I enlarge capsulorhexis, and this finishes the case. So I think with these few cases, I'd like to end my presentation here. And once again, I'd like to thank the entire executive committee of Ksos and Dr. Vanashri for giving me this wonderful opportunity. Thank you very much.
Okay. After that wonderful black, white, and brown cataracts, I would like to invite Dr. Soni George to give us some insights on the soft cataracts. So what happens is they look soft and they look very cuddly and nice, but they can be a nightmare for the novice surgeon. So Dr. Soni George, over to you, an excellent left-handed surgeon again with a lot of experience in phaco cases.
Thank you, Dr. Vanishri, for the opportunity. Good afternoon. Just one comment on your small pupil IFIS cases. Maybe moving a little anterior instead of the near limbal, if you go little anterior, maybe by 1 millimeter, that also could prevent even the side port from the iris to come out. Okay, from the hard brown, now we go to the soft nucleus. Many of us at some point of time would have thought that soft nucleus is easy, but it is probably harder than dealing with hard nucleus, basically because it is too soft to handle. Okay, and there's a lot of cheese firing, so all the established and defined techniques may not work because of the cheese firing. You may have a lot of corticocapsular adhesions, and because of that rotation, you don't have sufficient hard material to rotate. So that rotation must also be difficult. And there is no single technique which is perfect. So you may have to be ready to shift techniques, although you plan one and go ahead. And the chances of PC damage while sculpting and removal, etc., is very high because of the material being very soft. And if it is a small pupil, things become even more worse. Operating a soft cataract in a small pupil is definitely tougher than doing a small pupil heart cataract. And we have to make sure we are ready, like there should be good dilatation. You should be ready with hooks and rings if necessary. A good hydrodissection and a hydrodelineation is very imperative when dealing with these cases. And like I said, be prepared to shift techniques and use slow down whenever needed. And OVDs, generally we think OVDs are necessary only in heart cataracts, but here they are viscoelastic devices. So a few of the techniques, one is the chip and flip, and the stop and chop, and the stop and chip and chip. So most of the time after that you are not able to chop, then you keep chipping, and the lens salute. So these are a few of the techniques. So this is the advantage of a good hydrodelineation. You are able to rotate also. Here instead of in the center, you can just keep rotating from the periphery in a parallel way. And once you go through it, you give a little bit of chipping, remove some of the central nuclear matter, and after that it's very easy to flip. Make sure you have a sufficiently sized rexis also, not too large, but at least 5 to 5.5 centimeters. And then once that happens and things happen and you're able to flip the nucleus into the anterior chamber, I can go ahead with the cataract. Yeah. And yeah, this is another chip and flip, softer nucleus. And yeah, once you get it in one, you can use a second instrument to use the tumble the delineated nucleus into the center. And yeah, this is a soft nuclear lift. Once you go into the center, you can just use the phacoprobe and the second instrument to just lift it. Only the endonucleus is lifted up into the center, and with minimum energy you can go ahead and finish it off. And this is a stop and chop. I'm sorry for the quality of the video. Can you cut off the volume? Okay. So this is a slightly harder nucleus, but you cannot, even the rotation is difficult. So once you get and you divide into two, yeah, now you have two fragments, now things are much easier. Then you keep chipping. Actually, instead of the next chop, you just keep chipping. And yeah, this is what happens. Yeah, although you are not chopping, small fragments are coming through, and you keep rotating. And instead of the whole nuclear heminucleus coming, bits of nuclear fragments keep coming, and you can finish off the case with these. And this is where, if you have a doubt while sculpting, see, here there is a clear area in the center. So you do not know whether it is a rent. So what you do is, you immediately use viscoat, go and plug that area. You don't need to remove the phacoprobe at all. Once you do that, what you do is you try rotating, keeping the probe inside itself. If it is rotating properly, there is no problem in the rotation. Probably you are not dealing with a rent. And then once you're confident, you go in and start removing the fragments. Once one or two fragments are removed, then you can have a better view of the posterior capsule and whether there is cortex behind. And then that goes on as usual. And this is the Mohanda chopper which is being used. This is a useful instrument, especially in this thing with cheese wires. So it has got a nuclear sustainer and a chopper. So you sustain you should have a very good hydrodelineation and this thing. You rotate the nucleus, make sure it is mobile, and after that you go under the capsular axis and go to the equator with the sustainer, and on the other side you just move the two instruments together. Okay. And since there is a lot of it not clearly seen, the division is not clearly seen because of the soft material. But when you go in with the phaco machine, things are much clearer. See, it's already divided. You just need to support and remove the pieces one by one. And here is the lens salute. So here again you do a good hydro delineation and then you pop out the nucleus by hydroprolapse just like you do in SICS. Here you need to have a little larger rhexis. 5.5 should be sufficient. And once you get one pole out, then make sure you put sufficient viscoelastic behind the tilted pole also. And yeah, once you go in, then again lens salute. Make sure you don't go in with the irrigation on because you will push the saluted lens back into the bag and then you start chopping. And this continues. Yeah. Once that is done, you start from the, you can use the carousel technique if possible. Otherwise, you keep rotating the nucleus and then flip it inside, and then that is the end of the procedure. So in short, these are the few techniques which you can use to make life simple in a soft cataract. And whenever needed, please go ahead and use iris hooks or rings and OVDs in plenty so that you don't end up in a problem. Thank you very much.
Thank you, sir, for the wonderful insight. I think now we'll have a easier time dealing with soft cataracts. Next, I would like to invite Dr. Sandhya N. She's a prolific surgeon at Giridhara Institute, and she will share her insights on dealing with extreme axial lens, that is high myopes and the hypermetropic cases during phacoemulsification. Over to you, ma'am.
Thank you, Vanasri. So long eyes generally refer to eyes longer than 26 millimeter. So it is better to avoid needle anesthesia in these patients because of the increased risk of glauque perforation in these long eyes with thin sclera. This patient had an axial length of 27 millimeter and the IOL power was 15 diopters. So the capsulorhexis appeared to be smaller in these eyes because of the deep anterior chamber and wide pupillary dilatation. So we have to keep this in mind and should aim for a rhexis that will uniformly overlap the IOL optic all around. So these long myopic eyes have got a deep anterior chamber. So the clear corneal incision should not be too long because in that case you will have to hold the instruments vertically and that will make the surgical manipulations difficult and also can distort the wound. And also whenever you are introducing phaco probe into an eye that has got a deep anterior chamber, that is these long eyes, myopic eyes, you should reduce the infusion pressure so that there is no sudden deepening of anterior chamber which can cause pain to the patient and also can make the surgery difficult because you'll have to hold the instruments more vertically. The anterior chamber is very deep. At the end, a single piece lens was implanted. So these eyes, because of the low scleral rigidity, are more prone for what is known as lens iris diaphragm retropulsion syndrome. So here, whenever the anterior chamber is, whenever you're introducing the probe into this eye, so the iris is thrown back onto the anterior rhexis margin, and then there is an iridocapsular contact, and this causes a reverse pupillary block, and this causes sudden deepening of chamber and wide pupillary dilatation. So this will cause stretching of the ciliary body and pain and discomfort to the patient, especially if they are operated under topical anesthesia. So to reduce this, you can reduce the infusion pressure whenever you are introducing phaco probe into an eye that is already filled with OVD. So this can happen at any stage of surgery, and you can also lift the iris of the anterior capsule like this so that the fluid equilibrates between the anterior and posterior chamber, and the AC and the pupil, they come back to their normal size. So this patient had a myopia of minus 27 diopter, axial length of 35.05 and IOL power of minus 9.5 diopters. He also had a posterior polar cataract, and so in this case we should aim for a rhexis of around 5 mm so that if there is any unexpected PC rent, you can place a 3-piece lens in the sulcus. So no hydrodissection was done, no attempt was made to rotate the nucleus, and a thin trench was made, and then the nucleus was split into smaller pieces, and this was taken to the anterior chamber and emulsified. So you can see the void here corresponding to the posterior capsular plaque, and then up to the lens insertion everything was okay, but during OVD removal So a sudden split appeared in the posterior capsule, which was typical of posterior polar configuration, that is extending from equator to equator. But this has not crossed onto the anterior rexus, and also the lens was stable. So it was not disturbed and kept there. So because of the capsular bag IOL size mismatch, there can be increased rotation for toric IOL in these eyes with in these long eyes. So here the reference marking was done outside, and the axis is 5 degree. So a CTR was placed in his eye. So the CTR stretches the capsular equator and pushes the posterior capsule forward, so that the posterior capsule stick onto the IOL and the rotational stability will be there. So in case of soft cataract, in this long eyes with deep AC, you can prolapse it into the anterior chamber, and after protecting the endothelium with dispersive OVD, you can emulsify it. So now coming to short eyes. So these short eyes generally refer to those eyes with an axial length of less than 21 millimeters. So this patient had an axial length of less than 21 millimeter, and anterior chamber was shallow. She also had an iris and retinochoroidal coloboma, and there was a posterior synecdoche in the inferotemporal aspect. So all the corneal incisions should be beveled and should not have a long, should be beveled, so that there is less chance of iris prolapse in these eyes with shallow anterior chamber. And only little trypan should be injected. Sometimes it will go through the coloboma and stain the vitreous cavity. So during the rexus, you can see the lens started to move, and there was great difficulty in continuing with it. So this indicated generalized sonule weakness, and here the corneal incision can be slightly longer to reduce the incidence of iris prolapse. See, once you hydrodissect, what happens is the lens pop up, so then the iris will be prolapsed like this. So the iris was coming out to the clear corneal incision, so it was reposited carefully. And then whenever you are introducing this phaco probe through an incision where there was iris prolapse, you should switch off the infusion and then enter. So, and after entering the anterior chamber, you can switch it on. So the nucleus pieces were emulsified, here again using low parameters. And before withdrawing the phaco probe, OVD was injected so that there is no sudden chamber shallowing. So fluctuation in the chamber stability, sudden shallowing, and all this can precipitate choroidal effusion in these eyes. And so this, towards the end of the surgery, the anterior chamber became shallow, and then the PC was coming. So an Sinski hook was placed under the probe so that the PC won't be touched. And then as you can see here, the cortex was very sticky and it was not coming out because of the lack of counter traction by the sonules. And again, this is an indication of sonule weakness. That is, whenever the OVD was injected, when it was injected, the rexus margin was coming forward. So there was no vitreous in the anterior chamber. So when the CTR was inserted, you can see there was ovalization of the rexus. But when it was inserted completely, it became round because of the stretch of the equator, capsular bag equator. And then a 27 diopter lens was placed inside the bag. So this lens was almost filling the anterior chamber, and this was slowly dialed into the bag. So this patient had a refraction of plus 8.5 diopter in the right eye and plus 10.5 diopter in the left eye. And his axial length was 19.69, but the anterior chamber was 2.73. It was looking shallow in slit lamp photograph, and there was no choroidal effusion. So in this case, 2 partial thickness sclerectomies were made in 2 quadrants by the VIA surgeon, as you can see here. And then iris hooks were used to provide adequate visualization. So iris hooks are better in these small eyes with shallow anterior chamber for pupillary dilatation. You can also use BHEX ring, which has got a vertical height of only 0.1 millimeter. So you should never make a very small rexus in these eyes because there will be difficulty in pulling out these pieces from the bag. So you should make an adequate size rexus. And also you should never prolapse the nucleus into the anterior chamber and do emulsification there, because already there is less space and there is more chance of endothelial damage. And the clear cornea incision can be slightly longer to reduce the chance of iris prolapse. And then after hydrodissection, so the nucleus was divided into multiple pieces and then it was emulsified. It is important to maintain chamber stability and avoid chamber fluctuation to reduce the risk of choroidal effusion as told earlier. And then the endothelium was protected with a dispersive OVD and the nucleus was emulsified. Stuck. And then after placing the intraocular lens, the iris hooks were removed and the case was completed. So in phacoemulsification in eyes with extremes of axial length is not different but can be challenging, and so excellent results can be achieved by meticulous planning and execution of appropriate strategies. Thank you.
Thank you, ma'am. Excellent presentation of all the videos and all the tips given. I hope there's a lot, we have taken on a lot of tips which will be of great help to all of us.
Thank
So,
you.
I'll call our next speaker, Dr. Meenu Mathin. He's a senior cataract surgeon, Chaitanya Institute, Trivandrum. He enthralls the audience with his amazing videos and excellent oratory skills. Over to you, sir. He'll be speaking on subluxated cataracts and pseudo-exfoliation in particular.
Good afternoon, ladies and gentlemen. Thank you, Dr. Vanishri, for this opportunity. സച്ചിൻ ഇവിടെ ഇരിപ്പുണ്ട്. സച്ചിൻ ടെല്ലിങ്, സച്ചിൻ ഇവിടെ വെളിയിൽ വന്ന് നോക്കിയിട്ട് നീ ഇത് കുറേ നാളായില്ലേ സബ്ലക്സേഷൻ ഒന്നും മടുക്കുന്നില്ലേ ഇങ്ങനെ പറയാനാണ് ചോദിക്കുന്നത്. അപ്പോൾ അതുകൊണ്ട് ഐ വാസ് തിങ്കിങ് വാട്ട് എൽസ് ടു ടെൽ, ബട്ട് ദെൻ ഇങ്ങനെ സബ്ലക്സേഷൻ ഡസ് നോട്ട് ഹാപ്പൻ or we don't get subluxated cataract so very often, and every time I get a subluxated cataract I am scared because it is not a predictable thing. Some subluxation, each one is different. So the area of subluxation different, mobility is different, many things are different. So this is one of the most difficult cases to handle in phaco is what I consider for me. So that is why I find happiness in talking about this. So this is one trauma patient with subluxation. So you can see incision. Very important, there should not be leak, it should be an appropriate incision. I put dispersive viscoelastic first to plug this area, no vitreous in AC as of now. So paracentesis incisions to get ready for using iris hooks to hold the rexus. Now a little bit of vitrectomy. If you find vitreous there, do a little bit of vitrectomy and clear it off. Don't do too much, don't pull too much of vitreous from behind, you lose support. And the rexus is started, see the wobbly lens. There is less counter traction by the zonules and it's difficult. I'll show you another technique later. And then you get a good rexus, that is very, very crucial. I use iris hooks and later we'll see capsule hooks also which can be used. And hydrodissection, this is a soft cataract. Hydrodissection is very, very important. Do gently, do repeatedly and make sure it rotates. And then the technique is going to be the same but everything is slow. Do slowly, fake, but the energy has to be adequate for the type of nucleus. Don't reduce your energy. But your flow rate and the irrigation, everything has to be slow. And then the phacoemulsification happens as routine. Once that is finished, see, fill up the anterior chamber and then only exchange. So you don't want things to shallow and get more vitreous out. So now there is only minimal cortex left, and so my CTR goes in. I like going through the paracentesis and it goes into the area of zonular weakness first. That is my technique, my logic is that. And then towards the end, I use a forceps to hold it and bring it up to the rexus margin and use a second instrument if required to direct it into the bag. And then cortex aspiration, sometimes it's difficult when it is entangled within the bag with the CTR. But then if you find one loose area, especially where the eyelids meet, from there you can tangentially pull and bring out cortical bits. Again, exchange when you take out irrigation, exchange it with visco and don't let the chamber shallow. Now you can see a peaking there, and then do a little bit of vitrectomy without irrigation or even with your manual scissors you can cut off. There will be only a small strand there which will cause the peaking. So snip it off and then get clear. So this is a 3-piece IOL. So I load it, and for safety you can always land this IOL into the anterior chamber first, so that because sometimes it will swirl and it may hit on the posterior anterior capsule, the bag may get dislodged, all those things. So it is better, I would now suggest go into the anterior chamber, leave it there and dial it into the sulcus slowly. So you can dial it, or you can even hold the haptic and place it. Dialing it is also not a problem. So to look at the rexus margin, if the pupil has come down, I again put iris hooks and then see the edges and capture the optic into the rexus margin. See that and do if the pupil has come down, or use intracameral dilating device. So at the end I irrigate and form. But then towards the end also, when you are aspirating, see there is a little peaking here. So always use triamcinolone. I don't somehow like this triamcinolone, but then definitely good if you cannot see the vitreous. But if you can see at some stage, you will be able to identify vitreous without all these things. So once vitreous is seen, please do vitrectomy, complete it, and then finish the case. So again, this comes with pseudo exfoliation, with small pupil, with subluxation, with hard cataract. This case I've shown multiple times, but this seems to be a nice case, should be shown again and again because it has all the problems together. So this is the way you can do a rexus in a very wobbly kind of lens. So see here you can hold with two instruments. One instrument holds the cut area and the other that gives counter traction, and this one makes the rexus flap. So keep re-grasping at 2-3 different areas and then complete. Mostly you'll get a small rexus in this, and if it is too small, don't proceed. Always make a nick and then continue once more and make it large enough to come close to 5 millimeters. And then use your iris hooks or your capsule hooks to hold the lens till late, where you need to implant a CTR if the lens is going down, or if it is very wobbly, maybe you'll need a CTR. But then with the hard nucleus inside, it's better to wait for your CTR to get before you implant a CTR to get the nucleus out with this technique. Again, the OVD, which is a dispersive OVD, filling the bag is very, very crucial, and reduce your aspiration flow rate. These are the two cardinal things which will help you to stabilize the bag and the anterior chamber during surgery. After this, the CTR goes inside, the hooks are taken off now, and then this is the technique which I always follow. So you hold it and go close to it, use the second instrument, direct it and leave it. So then the iris hooks are released, and then place the 3-piece IOL into the sulcus, and once it is in the sulcus, you visualize. And again, we should remember the PC is not open. If there is a PC rend you are capturing, then it is okay, but otherwise the bag is full of viscode. So this viscode will collect fluid inside and it will inflate, and you'll get a capsular bag distension later. So aspirate below the lens as much as possible, and then under irrigation I'm capturing. This is a very good technique which will prevent decentration later. Because somehow there is some physics working and it doesn't decenter. So all my cases of subluxation now are 3-piece lenses in the sulcus with capturing with the CTR inside. So because of pseudoexfoliation, I have been given the topic of pseudoexfoliation. This is very commonly we are seeing this one now. CTR was implanted, IOL was placed, for 3-4 years you remain in the same place, patient will come back with this. If you transfer yourself to some other place, you may escape, but then they will find you and come to your place, and then they will say, I can't see. So these kind of spontaneous subluxations happen. So expect this. And CTR, so I'm using the help of our VR person. He brings up the complex. So this is one way to refix the bag without opening it, or you can always just remove it and do a regular glued IOL. So the flaps are made now, and then open up one area where you have to see the haptic optic junction. This is Gore-Tex. So I would like to tell you two things about Gore-Tex. This will never break, and this is 7-0. And it comes with a needle which is very stumpy, thick and short and curved like this. It is not useful to penetrate through the sclera and come out. Otherwise you have to straighten it and all those. So Dr. Chisum Fake has developed this snare technique, which is a little cumbersome, but this is useful to get this thing inside. So use a 27 gauge needle and thread it inside. Cut. This is a very long thread. You can make it into multiple things. Thread it inside, and while threading, it has to be dry. Be very, very careful. If it gets wet, it is very difficult. It won't go inside. Second thing is, using a forceps is very dangerous because it will flatten. If you press with this, it will flatten out this one. It will broaden. It won't go inside. So use your finger, dry finger, and a dry area, and thread it into this one. So 1 minute I have. So thread it inside, and this will come out of the needle, and then put the syringe back on. And so this is the snare which is going to go inside. So your regular 2 millimeter behind anterior limbus, it goes inside, and the haptic optic junction. Look for the haptic optic junction and penetrate. This goes behind the lens complex, and it penetrates the bag and comes out. So this the thread you can pull out because this is loose here. It can be pulled out through a paracentesis. Now you have to have a Gore-Tex thread which is cut, loose Gore-Tex thread. And that can be cut. 1 minute more, please. Loose Gore-Tex, one end of it is put into this snare, and you pull it out. So this part of the thread is, you get one thread underneath. So it has gone through the CTR IOL bag complex. And after that, the rest of the thread to be taken out, you repeat this. So one part of it is out. So the same thing now goes inside. You can prepare multiple. If the tip becomes blunt, you can take one more. And then this comes, so use this instrument and put viscode there and press down the lens bag complex so that you can go above it. Put more viscode, press it down a little. And now again the snare comes out. You pull out the loose end, take it out through a paracentesis. And this loose the other end of this Gore-Tex, pass it through that. Take it out, then you get the one loop cleanly passing through this one. So this is a very elegant way of doing. You have to practice it a little bit outside in the wet lab to get it clean in a complicated case like this. So this is repeated on both sides, and then the IOL is well centered, and you take out your PFCL and whatever you have put in, and then the knot which you make, it is always you better not to tighten the knot very much in the beginning. One makes slip knots initially and make the slip knot on the other side, and make sure you have not tightened it too much, and center the IOL well, looking at the Purkinje images, and then then lock the knot, and then the knot has to be pushed into through the sclerotomy which you have made, and so otherwise it will be too thick and it may erode through your flap which you have made. So this is another way to deal with the bag lens complex which is subluxated due to pseudoexfoliation. Thank you very much.
Thank you, sir. Excellent insights into managing subluxated cataracts. Next, I would like to invite Dr. Sai Kumar, sir, a wonderful mentor to all of us, and he's a past president of Ksos and medical superintendent at Giridhara Institute. He'll be talking about polar cataracts and associated PC rents. Over to you, sir.
Thank you, Vanishri, for having me in this course. The moment we hear about posterior polar cataract, your heart sinks. You are wondering what to do, whether you'll have a drop, whether you have to have a backup. So these are the things, the thoughts that go through your mind. So I have been given the topic of posterior polar with PCR. So I am showing only PCR videos, not the normal videos. But just a few points of introduction. Most of the posterior polars that we operate have an intact capsule to begin with. So either the capsule is so weak that it just happens, or one of your techniques during PPC is not right and you have induced a rent. That is what normally happens. The pre-existing PC rents, which we talk about a lot, in number, if you look at the total number of PPCs that we do, is actually not much. In fact, there are many who believe that pre-existing polar rents with fibrosed margins may have a slightly better chance of the PC not giving way compared to a normal PPC. Some PC runs are inevitable and some are due to small judgment errors that we make. So this is my first video. So as we know, one of the risk factors for having a rent during surgery is a large PPC. When you have about more than half of the capsule with large whorls of PPC, then you have a high chance. So size definitely does matter in these situations. So here I've stained the capsule. Whenever you do a PPC, try to do a good rhexis, adequate sized rhexis, because whatever happens, you have the sulcus there to fit in your intraocular lens. So I've gone in through just like my routine phaco, but here I had this ominous feeling that this is, I'm going to break this capsule. This is a very hard cataract, so I tried to make a crack and there it goes. So there you have the rent there. I am trying to retrieve at least one part of it so that my VR surgeon has less job to do. But the most of the thing has dropped down into the nucleus. Into the vitreous. So when you have this situation here, please don't meddle with the piece. I think this has been emphasized many times for all of you. But the moment it drops to the mid vitreous and you have this feeling that somehow I'll take it out, you'll end up in a lot of trouble. So make sure that you call for help. So here I have my VR colleague who comes in and takes out all the pieces from there. Triamcinolone, PVD, all that is happening, and then in goes the 3-piece lens, which is then captured with the optic is captured. So this patient actually does very well, and I actually have sutured the main wound as well. Now this was a small posterior polar cataract where initially I thought that I will easily get away with my routine PPC technique. My routine PPC technique is to do a very, very minimal hydrodelineation, probably almost nothing at all, just loosening up the area of the nucleus there. And then without any rotation, I chop small pieces and then mechanically move the nucleus into the center, into the phaco probe from various sides and finish it. But as I am finishing here, as I am doing my coaxial irrigation aspiration, I find that there is a PC rent there. So this is the typical, like Dr. Sandhya showed, this is the typical PC rent that you get in a PPC, a long linear PC rent there. Till this point, there is no vitreous. So that is the importance, or something that I want to emphasize, is the chamber maintenance. The moment you see a rent, don't come out, always remain there. There is a significant chance, I'm not saying percentages, but there's a significant chance that you have an intact anterior hyaloid at the end of your surgery, and you can still get away by not doing a vitrectomy in these situations. So here, before you come out, always fill the chamber with a dispersive viscoelastic, and then again here a 3-piece lens goes in and is captured. There is no vitreous there. I have not done an anterior vitrectomy. There was a small piece of cortex remaining there. I went in with a Simcoe cannula with a very low irrigation and removed that piece of cortex once the intraocular lens was implanted. So maintaining chamber is extremely important in all posterior polar cataracts. This was a femto PPC where the nucleus was a bit white. So I asked my colleague who does femto not to do the lens fragmentation. So only rhexis was done here. So again, I thought that, the femto rhexis gives you a very ideal sized rhexis so that you can place the lens in the sulcus whenever you want to. This had a large epinucleus, hardly any nucleus. So I'm going in with my coaxial irrigation aspiration and slowly trying to maneuver out. And here again, I have this linear large PC rent. So again, chamber maintenance extremely important. There was some vitreous in the anterior chamber, small strands of vitreous. So I'm doing a limited vitrectomy. And like Minu told, in all these situations, always have a 3-piece lens backup. There are surgeons who, you might have seen videos where you see that there is a linear rent, the rest of the capsule is normal. You can still go ahead and put in a single piece lens inside the bag. But if you have seen the rent, don't do that. This is my thought process and my advice. But if you have already put in the lens and then the capsule breaks and you feel that the lens is stable, don't touch that lens. Leave it there. So that is what I'm going to show you next. So which just to tell you that posterior polar capsules can give way at any point of time. So here again, routine posterior polar, my routine technique, I have put in the intraocular lens here. The lens goes into the bag. Till that point, the capsule is intact. And there was a small epinuclear, remnant at one of the paracenteses, and go in with my coaxial irrigation aspiration to remove that. And suddenly I noticed that there is a PC rent there. So this is even at any point of time, you can see the rent there. This is the linear PC rent that you can see even after the implantation. But if you have the lens being stable inside the bag, the haptics are oriented in a way that the lens is not moving. I have not seen a reverse rupture so far. We talk about wraparound tears where you have a rhexis cut and the rhexis cut goes behind. But so far, technically it can happen. You can have a PPC with a split capsule. It can come into the anterior capsular margin and break the rhexis margin as well. I haven't seen it so far. I don't know whether it's a described entity called a reverse wraparound tear. And finally, in Malayalam we say Varanulladu vazhi thangula. And in English we can say what has to happen will happen. So this was a posterior polar cataract where again I did everything well. The nucleus fragmentation goes on just like my routine technique, and I slowly break open the pieces, and without any rotation, using the Sinskey hook, I slowly manipulate the pieces into the phaco probe. And I'm done here. I'm going to inject Cohevisc inside the eye, and the cannula slips. Okay, the cannula slips, goes deep into the vitreous. So my scrub nurse has given me a non-lower locking syringe with a cannula, and I also, because you have to do it single-handedly. Your right hand is in with a coaxial irrigation, so you have to use a one-handed technique. So there it slips, and I got a heart attack when I took out the cannula. It was not when it went in. When I took out, I was wondering, oh my God, this must have gone and hit the retina somewhere. So that much deep it went inside, but luckily it has stopped short of the retina, and so you have to do there was significant amount of vitreous there. So I did anterior vitrectomy, And like in any posterior polar cataracts, it's a protocol in our institution. We always have backup 3-piece lenses. And so again, 3-piece lens goes into the sulcus with a capture. So in summary, always be prepared, whether it is a VR backup, whether it is an anterior vitrectomy, whether it is a 3-piece IOL, always have a backup. Get an informed consent from all your posterior polar patients. Even if you think it is a configuration, it is not a typical posterior polar, I can get away with this PC may not break. It's always safer to inform the patient that you have a capsule which is likely to give you problems and get an informed consent. Either do a peribulbar if that is the practice in your institute, or you go in and if necessary give a subtenance block, which is very, very simple, very, very effective. A good rhexis is extremely important. Don't make the rhexis very large, don't make it very small, ideal for a sulcus fixation with a capture. Careful with the hydro, either no hydro technique or minimal hydro technique. A gentle nucleotomy. Don't pull the nucleus too much from this side or that side, because that maneuver or even that cracking maneuver can cause a PC rent. Always, always maintain the anterior chamber. This is one thing that always has to be in mind. It is something that we have to practice in every phaco, in fact, not only in PPCs, but especially so in posterior polar cataracts. Never let the chamber shallow. The moment the chamber shallows, the thin capsule just gives way. So always remember that. And even the last wound hydration, don't take off your vigil from the eye. Normally once we put in the intraocular lens, we are sort of, okay, lens has gone in, now nothing is there to happen. So even the wound hydration, you have to be very, very careful and make sure you don't hydrate the wound or make the chamber very, very tight. So these are some PPC with PC rent experiences I thought I'll share with you. Thank you for your kind attention.
Thank you so much, sir, for the wonderful insights on posterior polar and PC rent. We come to the end of this session. Can we take a minute of discussion? I think it's 2:55. We can take. Okay, I would like to ask Dr. Sandhya, for these high myopes, do you, okay. In high myopes, do you prefer to use low IOP settings? What is your take on that?
In high myopes, it's better to use low IOP. Not only in high myopes, it's generally better to use low IOP settings, because that time the turbulence within the anterior chamber will be less, and so the corneal clarity will be more. The pieces won't fly away and chamber stability will be there. And especially in these high-risk patients, like where you want to slow down things and you don't want chamber fluctuation like eye phase, high myopes, then posterior polar cataract, and those things, it is safer to operate under low IOP.
Okay, ma'am. Thank you. Just one point I would like to share with all of you, especially who are decently good phaco surgeons but scared to take on more difficult cases or tricky situations. What I would like to say is, go and watch a lot of videos. There is a lot of material available out there on YouTube. Many surgeons are putting up their surgeries. And I think that has a role, because when you watch surgeries, it kind of goes into your subconscious. And when you're operating and faced with a situation, you do tend to remember these points, and it helps you to improvise your surgeries and come out without complications, or, handle your complications well. Thank you so much for attending. And thank you to all the co-speakers who have been my mentors. And thank you for being a part of this IC.